Hi, everyone. This is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And I want to welcome you to today's Journal Club. Of course, I always like to thank ESGO and IGCS for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so that everyone can hear the presentations. If you're having any difficulties or questions, please send a message in the chat and our technical support will assist you. We will have time for questions and answers, and actually we do encourage questions. You can submit your questions via the chat function throughout today's session. So with that, we're going to start our journal club. This month's lead article is the Surova study, Global Real-World Treatment Strategies and Mortality Risk Prediction in Advanced Ovarian Cancer by Luis Chiva from Cancer Center, Universidad de Navarra, Madrid, Spain. I am so very, very pleased to welcome you, Luis. It's always great to see you. I want to thank you for accepting our invitation. Thank you for sending the Surova study to our journal. I'm really delighted and looking forward to your discussion. And I also want to thank all of the fellows who have put in all of the questions for this journal club. So we're really very, very excited about getting the discussion started. But before that, Luis, welcome once again to the journal club.
Thank you, my friend. I cannot, I have not words enough for showing my appreciation I'm so happy to be with you today. And overall, I want to take advantage of this presentation for saying that, you as fellows of or people in the audience, it's for us an incredible honor to have Pedro Ramirez as editor of this journal. He has done an incredible job. I want to take advantage for you to tell, to share with you that we are organizing an incredible meeting in Madrid next November, next year for, having a special tribute to my good friend and colleague Pedro Ramirez. So, after saying that, I want to present today the findings of the Surova study, a global real-world treatment strategies and mortality risk prediction in advanced ovarian cancer study. This is a large international effort that was conducted by a number of researchers that altogether are named Surova Study Group. And as you know, advanced ovarian cancer remains one of the most lethal gynecologic malignancy. For decades. The standard approach has been primary Balkan surgery or PDS, and neoadjuvant chemotherapy followed by intervention has emerged as a common alternative. Previous randomized control trials such as EORTC, Chorus, Scorpion, the Japanese trial supported the non-inferiority on neoadjuvant, but often suffer from critics due to the selection bias and low completed resection rate. And even more recent trials like the TRUST trial have offered mixed findings, has been a negative study. But beyond that, in our community exists or persists a lively debate among clinicians regarding the best initial approach. Therefore, the main goal of our study was again to compare 5-year overall survival between PDS and neoadjuvant using one of the largest available data set of global real-world data, and we aim to bridge the gap between selective clinical trials and everyday clinical practice. So Surova is an international retrospective observational cohort study. We collected data from a huge cohort of 3,286 patients treated between 2018 and 2019, and this cohort spanned 174 centers in 55 countries, providing a great reflection of global practice and using pretty much the same inclusion criteria than the TRUST trial. So, in observational studies, as you know, treatment usually, and especially in this setting, comparing neoadjuvant with primary Balkan surgery, retrospective observational studies are tricky and are inherently unbalanced. Indeed, before adjustment, a PDS patient, primary Balkan surgery patient, has a better median survival, as you can see in the slide, 71 versus 55, as all the well-known retrospective studies in the literature, corresponding at a 32% higher risk of death for neoadjuvant patients. And something has been, well known in the literature in the community. So to account for these initial differences, we applied the very well-known propensity score matching, and we were able to match 762 pairs with a total of 1,524 patients based in 7 critical baseline variables that we knew from the statistical point of view that were very relevant, as age, rates, ECOG status, CA125, H4 disease, ascites, and tumor grade. And after achieving the adequate covariate balance, the result in the overall match scores was striking because, again, as in the TRUST trial, the curves were very similar. Median overall survival was statistically similar between primary debarking surgery and neoadjuvant, 67, 65, no differences. And this overall similarity, however, masked crucial differences driven by patient-specific factors. Our analysis showed that treatment outcomes differ significantly by ethnicity and post-treatment follow-up. First, let's talk about it. Ethnicity, because Asian patients, who represent 40% of our match cohort, showed an exceptional response to neoadjuvant chemotherapy. For this subgroup, neoadjuvant consistently favored better overall survival that was significant with a hazard ratio of 0.31. And these findings suggest, at least as an speculation, that the ethnic differences may influence platinum sensitivity and require, in our case, from the statistical point of view, a separate consideration in treatment planning. And second, in our curves that were crossed, after 24 months, there was the time-dependent effect in non-ASEAN patients because the proportional hazard assumption was violated because the survival crossed at 24 months. In the first 24 months, neoadjuvant outcomes curves were similar or slightly favorable, likely because it avoids immediate surgical risk, and between 24 months, however, primary debarking surgery provided a clear long-term advantage that was, again, significant with a hazard ratio of 2.02. So this is two different stories, two different ways of looking at the curves, and this means that the true benefit of PDS is realized years after the initial treatment. So what is, the other point of the study is that, SUROVA study provide a deep insight into the impact of postoperative complications. We always have been talking about the importance of complete resection, and that's it. And we thought that for years that with complete resection, the best curves is always, in cases of primary debarking surgery. But in SUROVA study, complications of any grade occurred in 28% of the patient, and the presence of complications significantly worsened the overall survival, dropping the median overall survival almost 2 years, from 66 months to 46 months, with a hazard ratio of 1.5, which was significant. Of course, we're talking about in non-Asian patients because the Asian patients were retired of the study. For not Asian patients without complications, primary debarking surgery provide a superior median survival of almost a year, 73 months versus 60 months, which was significant again. However, and what is interesting is when complications occur, both treatment groups had similar diminished outcomes of 46 months. And this implies that complications somehow neutralize the potential survival advantage of complete resection. And of course, what is interesting, as in other studies we have been shown, is that the most favorable outcome with median overall survival not reached was in the group that underwent primary debulking surgery with complete resection, and this is new, and no complications. And this is important because this ideal subgroup represents only 27, almost 30% of the entire study population, less than 1 out of 3, and 53% of all the patients who underwent primary debulking surgery in the Surova study. So this is important because probably we are, using, this is my perspective, right now in the real world, probably, we are more than we should primarily debulking surgery than neoadjuvant chemotherapy. So in conclusion, while overall survival was similar between primary debulking surgery and neoadjuvant chemotherapy after matching, treatment's effects varied significantly, and Surova supports the need for individualized treatment strategies based on predicted resectability, perioperative risk, and ethnicity. Neoadjuvant chemotherapy probably in the future may be more appropriate for patients with significant risk of complications, lower likelihood of achieving complete resection, as we used to do, or even in some, if this has been in the future is valid, of those with Asian origin. And primary debulking surgery should be reserved for carefully selected patients with complete resection is highly likely and the risk of complication is lower. Our findings underscore the critical importance of careful preoperative patient selection and aggressive complication prevention to maximize the long-term benefit of primary surgery. And finally, as you know, within the paper, to assist with this personalized decision-making, the study developed an internally validated Surova risk calculator. This tool estimates individualized mortality and relapse risk based on pre- and postoperative clinical factors, providing actionable insight for clinicians. So I would like to express my deepest gratitude to this exceptional international team of researchers because their generosity in sharing data reflects a common purpose to improve survival and make a meaningful differences in the lives of women confronting this disease. And thank you. This is, a summary of the study in 3 slides, as the moderator wants to.
Well, thank you so much, Luis. You gave us a lot of important information within a short period of time. So we really congratulate you in relaying all of this information. And I wanted to just start with discussion about now we have 5 prospective studies showing no difference. In addition, the Surova also showing no difference. And in fact, actually, even potentially going beyond that, suggesting that if you do get a complication, your outcome is going to be significantly worse. So I think the argument for a standard routine primary cytoreductive surgery, I think, is a paradigm of the past. And I think you brought in a very important point with regards to patient selection. And what we're seeing, I think, in our field is that there is increasingly better tools to select our patients, increasingly better judgment by our gynecologic oncologists to select our patients. And that ultimately, again, ideally, obviously, what we want to do is what is best for our patients. So with that, I'd like to start the questions from our group. And first, we're going to go to Italy with Tommy Meschini.
Hi, Dr. Chiva. Thank you so much
Hi,
for this wonderful
Tommy.
presentation.
Tommy, nice.
And I want to ask,
My pleasure.
hi, thank you again for this wonderful presentation. And I want to ask, in the manuscript, it is stated that the included patients were considered completely resectable by the surgeon. Could you clarify how resectability was determined? Specifically, were patients assessed through diagnostic laparoscopy, for example, using the Fagotti score or similar criteria, or was the decision based solely on preparative imaging and clinical evaluation?
Tommy, thank you for this question, which is very relevant. Well, in Surova, resectability, to be honest, was assessed according to local institution practice, reflecting just the real world nature of the study, right? Diagnostic laparoscopy was not mandatory, and no informed scoring system such as the Fagotti was required. In most centers, resectability was determined based on clinical evaluation by preparative imaging, CT, MRI, PET-CT, performance status, and the honest judgment of the operating surgery, often with a multidisciplinary tumor board. I mean, like in many other places. Patients were included only if not resectable in Surova, only if not resectable disease had been reasonable exclude using the tools routinely available at each center. So this approach was intentional. The study was designed, this is important, to mirror the philosophy of trust, but in a real world global setting, aiming to provide a snapshot, a picture of how advanced ovarian cancer is actually managed worldwide rather than enforcing a single assessment strategy. So despite this heterogeneity, the study achieved a 74 complete resection rate, higher, we can discuss this afterwards, higher than in trust, which is not only reassuring, but even higher than other studies. And we believe that this supports the external validity of our findings while acknowledging the inherent limitation, of course, of this type of real-world data.
And I think actually to a follow-up to that, I think Luis, that brings up the somewhat of an overestimate in terms of the enthusiasm when we're collecting retrospective data, because if you look at the highly selected centers by the trust trial, the highly selected surgeons, then out comes a study that is real world that happens to have a better resectability than the highly selected centers. So it gives us an opportunity to put things in perspective with regards to how often overly inappropriately enthusiastic surgeons may potentially be.
Completely agree, Pedro. Probably this is the one important bias in the study, because people try to show the good results that they have, and probably to really that fulfill perfectly the inclusion criteria of resectability, because they knew in advance which patients were completely resected. You're right.
Excellent. So Joanny Nouveau from Canada is not here with us. She couldn't be here. But Tommy will ask her question.
Yes, I will take her question on behalf of her. And the study used propensity score matching and time-dependent Cox models to compare primary versus IDS. Given this heterogeneity, do real-world data analysis like Surova better capture global practice pattern than RTC like Trust, or do they risk introducing more bias than they resolve?
Tommy, Joanny, thank you. This is an excellent question. Again, I'm very glad you asked it. I mean, really, indeed, randomized control trials like TRUST remain the gold standard for searching causal inference, causality. They minimize bias through randomization, centralized protocols, very strict eligibility criteria. However, on the other hand, that they are extremely expensive, complex, slow to reproduce, and by design they represent, in this case, in trust, for instance, a highly selected reality that unfortunately usually limited to expert centers. And on the other hand, real-world study like Surova's try, to show a different but complementary, with a complementary purpose. They provide a Polaroid picture of what is actually happening worldwide across countries, healthcare systems, and levels of surgical expertise. This reality is something that the randomized trials, by definition, cannot fully capture. Of course, that real-world data introduce bias. The key point is whether we acknowledge, measure, and mitigate it, right? What has been striking for us after several large real-world studies is how consistently the survival curves of our studies, trends, and signals mirror those of prospective trials. For instance, Sucor anticipating findings, later confirming prospectively regarding the cone, regarding the vaginal maneuvers, the manipulator, and Surova closely, completely aligns with the trust in its main conclusions. I mean, if you compare the curves, are incredibly similar, right? Despite this completely different methodology. So to answer your question directly, real-world studies do not replace randomized trials, but when done with rigor, with rigorously, they add truth rather than noise, right? Broaden our understanding, help translate trial evidence into everyday clinical practice.
Excellent. Thank you so much, Luis, for that answer. And I think for the younger members of our audience, you may need to clarify what is a Polaroid picture. We'll go to a question from our audience, and this is from Payam Kashi. He's asking about peritonectomy. Could you elaborate on the comparative outcomes of complete peritonectomy versus spot peritonectomy? Do you think doing one versus the other impacts progression-free survival and overall survival? Does the method used depend on tumor biology?
Well, to be honest, I don't have an answer for that. Probably, if you perform a study on that, probably you can answer this question. But I don't have information enough in the literature for doing it. We are not performing complete or universal peritonectomy in neither primary debulking surgery nor interval debulking. So there is no point for that. The only thing that you, from my humble point of view, is to produce, harm, because at the end of the day, you are leaving peritoneum in many other places, in the surface of the liver, in the surface of the spleen, in the serosa of the bowel. So, I mean, probably, I don't know what will be the future of the surgical procedures in ovarian cancer. So far, are still relevant, but I think that there only some general surgeons are performing, the sugar-baited procedures, removing the whole wall or the whole potential resectable peritoneum of the abdomen. This is my perspective, right? So I'm just removing the peritoneum with disease, with macroscopic disease in my practice.
Yeah, and I think these days I find that if you're removing and doing a peritonectomy, likely that patient needed neoadjuvant chemotherapy rather than the actual peritonectomy. Excellent. So now we're turning over to Masha Parvin from the University Hospital of Münster in Germany. Masha?
Thank you so much for this presentation. Based on your data showing the most favorable outcome is achieved in patients with primary debulking and complete resection and no complications, we should really learn how to anticipate or predict the complications accurately. Do you have any idea, or how do you do this now? What do we need to do going forward?
Masha, thank you very much. This is a key point, and this is one of the key points or the key conclusions. So, in the Surova study, because Surova really forced us to rethink primary surgery. What we show is that the survival benefit of the primary debulking surgery is conditional. It only holds when we achieve complete resection and avoid postoperative complications. Once complications occur, even low-grade ones, this is something that we can discuss afterwards, the long-term survival advantage essentially disappears. But disappears, no, it's pretty much like the interval debulking. So it's not worse, it's like interval debulking. Because of that, the challenge is no longer only predicting resectability, but accurately predicting complication risk. And this is not theoretical. We are already working, in our group, Quique Chacon, more specifically, on a specific complication risk score that, by the way, has been accepted for an abstract for all an abstract in Copenhagen, right, in ESGO, because we are trying to identify patients in whom surgical morbidity is likely to negate the benefit of primary surgery. In the some terms, this means integrating complication risk into upfront decision making, along with performance status, ascites, stage, expected surgical complexity, using prehabilitation and standardized perioperative pathways to actively reduce that risk. Looking forward, I think that our field right now in approaching the first treatment needs two things. First, carefully supervise real-time learning systems, probably within artificial intelligence models, trained on high-quality real-world data to assist clinicians, not replace them. And second, prospective trials in the future where the intervention is not the surgery itself, but the selection strategy. Comparing standard decision making with risk model guide treatment allocation. Ultimately, at the end of the day, Surova tell us that preventing complication is not just about surgical quality. It is complications. Preventing complication is a key determinant of survival.
Excellent. Thank you, Masha. And congratulations, Kika. We look forward to attending your presentation in Copenhagen. And very excited to hear what the results actually showed. Next, we are going to Masha. Masha already. Masha, you want to ask Mo Burns questions? Mo Burns from Memorial Sloan Kettering Cancer Center. And I know, Mo, you had also a comment in the chat, so please proceed.
Oh, hi, Dr. Chiva. I would be remiss without saying hello from Dr. Chi. He's a big fan of yours, and he asked me to say that. My comment in the chat was more just, another way that your study mimics the real world is that in TRUST, when patients were open, they had to proceed with resection. And I think in the real world, if we open somebody or scope somebody and they're unresectable, we wouldn't proceed and would send them to neoadjuvant. And so I think your study kind of mirrors real world practices in getting that higher CGR rate and that we would in everyday practice. But my question for you was similar, kind of jumping off of Masha's point, was how do you guys in your institution risk stratify? And, now that you have those predictors from this study, what is the line that you're drawing in the sand of who are you bringing? What is the amount of risk that you would deem acceptable when identifying a patient to take to the OR?
Well, I'm going to try to be very honest because at this moment we don't have a fully validated institutional tool to stratify complication risk. This is my first idea.
I don't think any of us do.
So what we have is an structured clinical approach, and we are actively working on a dedicated complication risk score, as I told you, with Kike, that we are presenting shortly, right? But but we are somehow concerned on that. So we are discussing now in the tumor boards. So in daily practice, our decision making is mainly driven by two variables: patient frailty and expected surgical complexity, as in many other places. Now, frailty includes age, performance status, nutritional reserve, overall physiological vulnerability, and then surgical complexity is estimated from imaging, PCI, ascites, and importantly, anticipated need for upper abdominal or multivisceral procedures. So the key question at tumor board is not only can we achieve, as we used to do, a complete cytoreduction, but can we achieve complete cytoreduction safely? If predicted complexity is high and the patient is borderline from a frailty perspective, we assume that the risk of complication may outweigh the benefit of primary debulking. This is exactly what we are developing with a formal complication score integrating variables as I want to anticipate something, no? Age, PCI, surgical expertise, complexity, and estimation of operative time, to move from a subjective judgment, which is what we are doing, to something that can be reproducible, right? Stratifying the risk. At the end of the day, the goal is to align patient selection with what Surova shows. Complete resection only translate into survival benefit when complications are avoided, which is important. I want to remember that complication is any complication. Of course, it's different, right? But grade 2 complications, for instance, that was, I don't know, Mo, it was searched by Dennis Chin Memorial, and they found that, in Memorial, that again, low-grade complications produce, a worse result, long-term worse result in survival.
Excellent. Thank you so much, Luis. I'm going to turn to a question from the audience. Isam Lataife, were BRCA HRD statuses available? Was the maintenance therapy PARP and BEV accounted for?
So you mean if we had, information on HRD and BRCA mutation, right? And the answer was not. Almost no data on that. Why? Because we collected patients from 2018 and 2019, and unfortunately we had not that data. We have a surrogate of that, which is, the use of PAR inhibitors in primary setting and in the relapse, and the overall use of PAR inhibitors at any time was 20% and was perfectly balanced in primary and interval debulking. Meaning what? I think it was 10% in primary setting, and as you remember that the first studies in New England and so forth were, published in 2018. So there was no time at that time, for using the HRD and the BRCA. But we had, a rate of PAR inhibitor use in primary debulking of 10%, and after relapse 30%, which makes an average of 20%. And it's clear because when you see the curves are much better. So there was, for sure in those patients, great response to platinum and probably, mutated patients. But I'll tell you something. Our next study will be, to ask for the slides for the paraffin and BEP of those patients and to get deeper into this, research. Thank you.
Excellent. So, Luis, we'll turn over to Paulo Mateo from Houston Methodist now.
Hey, thank you. Thank you so much for the presentation, Luis. I
Sure.
wanted to ask about the risk calculator, race, and ethnicity. Why did you decide to exclude Asian patients, but not other minority groups such as African or Latin American patients?
Well, because for many reasons, because probably the most important ethnics that we have beyond the Caucasian were, the Asian on one hand, but we explored in the very beginning, the behavior of the patients of the different ethnics, and Asian patients was completely different. We were really astonished with that results, right? But the exclusion of Asian patients from the clinical risk calculator was not based only, in the ethnicity per se, but on the clear methodological use identified during the analysis. In Asian patients, we observed a clear difference between treatment effect, particularly a much better response to neoadjuvant chemotherapy, which result in a violation of the cost proportional hazard assumption. It's like you take a aspirin and you have a different effect. You cannot use this population to put together with the other one, right? And this type of results has been seen in the literature at the time in many circumstances. For instance, in the study of the ethnicity of the US database that showed that the best results are in the Asian population. So, in other words, the relationship between the treatment and survival over the time behaved differently in this subgroup, making it statistically inappropriate to include them in a single unified risk model. By contrast, other minorities such as African or Latin America did not show a distinct or heterogeneous treatment, a fate that violated the model assumption. So their survival patterns were aligned with the overall population, and therefore their inclusion didn't compromise the validity of the calibration of the calculator. So this decision was driven entirely by the statistical robustness and model validity, not by demographic consideration. In fact, including Asian patients would have reduced the accuracy and clinical reliability of the calculator for all patients. So this doesn't mean that the Asian patients are excluded for analysis. No, rather it highlights the need for separate population-specific models, which we believe is important for future research.
Excellent. So we'll turn over now to Toulouse friends, Mathilde Del.
Thank you very much for your presentation. You have already partly answered my question, but what is the current applicability of the Surva risk calculator in daily practice? And should it be used during a multidisciplinary tumor board discussion to tailor maintenance treatments or follow-up strategies?
Well, this is a relevant question again, Matilde. At this moment, I see the main value of Surova calculator as a decision support rather than a prescriptive, tool. Its real interest in daily practices that it allows us to generate scenarios during the tumor board discussions by modifying. You may modify key variables such as approach, neoadjuvant, primary debulking, complete versus incomplete, presence or absence of complications, use or not use of PARP inhibitors, and then you have a tool that can estimate the risk of relapse, the mortality rates, and the different clinical pathways. And this can help frame the discussion in terms of risk. What risk are we assuming if we pursue primary surgery in this given patient? Or what is the potential benefit? What is the potential realistic gain if complete resection is achieved without complications? So rather than use the calculator to dictate the type of therapy I think the role is to support decision shared among the group decision making, helping us visualize trades-off and align treatment strategies with patient-specific profiles. So in that sense, the Surova calculator is best used at the tumor board to inform a strategy, not to replace at all the wise clinical judgment.
Excellent. So now, Luis, we'll turn to Carlota Sabini, and she'll be asking the next question.
Hi, thank you so much for the amazing presentation. And my question is, how do you see Surava complementing a randomized trial in refining patient selection for PDS versus neoadjuvant chemotherapy? And to what extent can large real-world data sets like these help bridge the gap between controlled trial evidence and everyday clinical practice?
Thank you very much, Carlota. It's a great question. Well, I see Surova and the randomized trials just as complementary rather than competing. Trial like TRUST establish efficacy under optimal, highly controlled conditions, and they tell us, what can be achieved. This is clear. Surova address a different question: how those studies perform in routine practice across diverse patients, centers, and health system. What Surova, I think, that adds is a refinement of patient selection. It shows that the benefit of primary debulking surgery is conditional, maximized with complete resection and no complications, and potentially lost when complications occur. So that helps identify patients in whom trial-based strategy may not translate into real-world benefit. In that sense, I do believe that large real-world datasets help translate trial results into everyday practice, supporting more individualized decision between primary surgery and neoadjuvant chemotherapy.
Thank you
Excellent.
so much.
We'll
Thank
now
you.
turn it over to Gemelli Hospital, Mateo Lovero.
Thank you. Thank you very much. And I'm going to do very probably similar question. And given the growing availability of large-scale real-world data sets and the rapid progress of artificial intelligence in data interpretation, do you see a future where AI-driven real-world evidence could replace or integrate randomized trial data as the main source for clinical guideline development?
Well, amazing question, right? Because it is one question that we ask ourselves all the time. And personally, I don't think that randomized controlled trials can be replaced. Honestly, they remain the gold standard. That's true. That's clear. When and when those randomized controlled trials are well designed with a prospective randomization, that reduce bias in a way that is simply unmatched. But after saying that, I do believe that artificial intelligence-driven real-world evidence will increasingly integrate with randomized data. Why? Because if real-world studies are carefully designed with high-quality data and with high-quality data capture and stroke quality control, they can answer clinically relevant questions much faster than prospective trials. We are often waiting 10 years for mature results for randomized study. In contrast, I put together all the information of Surova in 6 months. In 6 months, from January to July, I have 3,000 patients. So these large real-world data sets, especially when supported by artificial intelligence, can generate and test hypotheses in much shorter time frame. Sometimes producing evidence that closely mirror trial results. So I don't see real-world evidence replacing randomized trials, but rather accelerating discovery, refining patient selection, and helping us decide which questions truly need to be tested prospectively. In that sense, artificial intelligence becomes a bridge between clinical trials and real-world practice, but not a substitute for rigor.
And it is much cheaper too than a random.
Definitely. I spent nothing for doing, and what is very interesting is we have now a network of collaborators around the world that they are they are asking me to start with the next one, right? Because it's an opportunity to have, authorship, publications, and it's very exciting because please, in the supplementary part of the study, in the journal, you may have, the last supplementary slide is showing the differences between the curves of TRASH and Surova and are completely identical, right?
Excellent. So we'll, as a follow-up to that question, actually, Saniru in Mexico will ask the next question.
Hello, thank you very much. Can you hear me well?
Saniru.
Yes, hello. Nice to see you. Nice to see you. Thank you very much for your amazing presentation. Thank you very much.
Un placer y un honor. Deseando ir a México.
Bienvenido a México cuando guste. Más
Claro.
que bienvenido. My question is now, thank you again. One of the strengths of real-world evidence is external validity, right? And what patients or treatment characteristics did you observe that differ from what we typically see in randomized trials, just like Dr. Pedro Ramirez said before, Chorus, Ross, ERTC?
Yeah, well, important question, Saniru. I think that the first step is to clarify which trials are really comparable, because ERTC, Chorus were conducted, 15 years ago, 10 years ago, in a very different therapeutic and surgical context. So direct comparisons with Surova are very limited. But if we focus on TRASH, which is much closer in time and philosophy, the baseline patient characteristics are actually more similar than one might expect. age distribution, FIGO stage, histology, performance status are comparable. And both studies include patients considered resectable upfront. Probably one more optimistically selected, as Pedro was saying, but are pretty much the same. I mean, the rate of I don't remember, but it's 74 for Surova, and for the rate of complete resection for TRAS is 68 or something like that. The main differences that we observed are therefore not by the patient level, but at the system and treatment level. TRUST is a highly controlled randomized trial conducted exclusively in accredited high-volume center with strict surgical quality assurance, whereas Surova intentionally captured a wide range of centers, surgical expertise, and perioperative practice across multiple centers. This leads to a great variability, surgical complexity, complication rates, access to maintenance treatments, and postoperative management, factors that randomized trials are designed to minimize, but which are intrinsic to real-world practice. But again, what is striking, however, is that in Surova we observed higher complete cyto reduction rate, and therefore longer survival that might be expected when compared with TRAS. You remember that the median overall survival in Surova is 65 months. 65, which is the median survival in TRAS was 56 or something like that. And you remember that the classic curves of the German group was, for complete resection, almost 80 or 90 months. So, well, this is what has happened. I don't know why. Probably this raised the possibility of a degree, as Pedro was saying, of selection bias inherent to the optimistic view of the real world researchers. And some just may have preferentially include in our study patients who were more clear resectable. So yes, selection bias may partially explain these findings, but rather than undermining the results, this actually reinforced the central message. The benefit of primary surgery in real world is highly sensitive to patient selection and is only fully realized when complete resection can be achieved safely. In that sense, TRUST tells us what is achievable under optimal and tightly controlled conditions, while Surova helps us understand how these same strategies perform and sometimes fail across routine clinical practice.
Excellent. So we will go to our last question from our fellows from Spain, Itzi Villagra.
Hello, Luis. Thank you for this amazing presentation. Well, you participate in 3 large retrospective studies, the SACOR, the Seneca, and Surova. If you started another, what methodology and preparation would you do differently?
Itziar, you know that Itziar was with me in Africa once, 3 years ago. It was an incredible experience. Thank you. She's from San Sebastian and she trained in La Paz. And I know for many years her mother as well. So thank you for the question, Itziar. Thank you. It was a very fair question. And actually, we have done not 3, but 4 large retrospective studies: SUCOR, Seneca, Surova, and Daydream. That is still unpublished. I was, pushing Alejandro this morning to publish in our journal this interesting study on sarcomas. What we have learned from all of that is that the success of real-world research depends on much more on the preparation phase than on the statistical analysis itself. This is important. If we were to start, and Kike knows this very well because we are discussing all the time, another study today, we would clearly invest much more time upfront in methodology. When we first started working with real-world data, with SUCOR, I remember perfectly the day that Pedro told me I got the results from the LAC trial. I mean, I have a seat because I have to tell you something. But, afterwards I decided, to try to know what's going on in Europe, and the results were pretty similar, even though we didn't use the cone. Well, however, anyhow, when we starting, we found a sentence that was very enlightening for us that says, observational study can certainly contribute to valuable evidence supporting causal association, but only when they are designed and conducted using rigorous methods. So what really helped us was realizing that most of the flaws in real-world studies are not intrinsic to be an observational research itself, but rather related to outdated methodology, uncontrolled confounding, heterogeneity in reporting, lack of replication, and poor interpretation within the limit of an observational research. So the idea gave us a lot of clarity. The problem is not real-world evidence per se, but the quality of the design. So practically, this means being much stricter with inclusion and exclusion criteria, refining the case report form to avoid ambiguity, defining key variables such as resectability, residual disease, complication, treatment intent with absolute precision, especially when data collection is done by collaborators or fellows rather than by the principal investigator themselves. So to finish, the main lesson we learn in this type of studies can be extremely powerful, but only methodological if the methodological rigor is front-loaded. In retrospective research, clarity at the beginning saves enormous problem at the end. This is our point of view.
Yeah. So Luis, certainly, again, we really enjoyed your conversation and thank you for your insights. As a closing statement, certainly, obviously, you have been a pioneer and a strong advocate of primary cytoreductive surgery. As we continue to learn from all of the studies, and as you mentioned, from phase 3 trials, 5 trials already that show us that there is no difference in terms of the approach, either neoadjuvant followed by surgery or surgery followed by neoadjuvant. And now your own study also showing no difference. What is your approach now when you have a patient with advanced ovarian cancer, knowing all of the data that we have available to us in having that discussion with the patients?
Well, this is great. Thank you, Pedro, because this is the most important, conclusion of this journal club. I think we have to include, the patient in our conversation and our discussion, showing this type of results and say, listen, we can try to get the best cure that we, as far as we understand, is, complete resection, probably is resectable. But we have to try to avoid complications. We have to be clear cut, very clear with the patient, and then to be very honest with ourselves. We have been honest trying to define the criteria for resectability, and now the important thing is, to do an incredible job when you are operating, thinking that complications, matters, are important, and to be honest, and send to neoadjuvant if you think that the patient is, borderline or clearly fragile, to avoid, damage. Yeah, right. So for instance, I'm pretty sure that the rate of complete resection that is necessary for obtaining quality indicators in ESGO, for instance, will change. So this is just a poor observational study. We have to wait for the publication of trust. Do you know something about the publication of the paper of trust? When it's going to be published? Where is going to be published? Because probably it's not going to be published in New England anymore. What do you think?
Well, Luis,
you cannot say anything.
Thank you very, very much for that very insightful conversation. It really, really, again, enjoyed it so much. Congratulations on such a large study and really the work that you have put in and all the collaborators as well. I would also like to thank all of the fellows who participated. This is their concluding journal club, and I will definitely miss you all and absolutely have done an amazing, fantastic job. Hopefully I will see you all in Copenhagen to celebrate. And congratulations to all of you who have had your abstracts accepted to the ESGO meeting in Copenhagen. And I also want to congratulate some of the 2026 fellows that I see them already in our journal club and joining. So congratulations to you, and I look forward to working with you. And once again, I want to thank you and wish you all a very happy holiday.
Thank you so much.
Thank you.